Welcome, everybody. This is the Rotary E-Club of Silicon Valley. Every week, we bring you the stories of people making the world better in some fashion, whether they are doing that locally, globally, digitally, or some combination of the above. It is part of what we do in Rotary to try to improve communities in all sorts of ways. From our perspective, in our Rotary E-Club of Silicon Valley way, we love to see this happen in all sorts of innovative ways. Are there possibilities for making strides to make certain kinds of service efforts more sustainable? Are there ways to disrupt an industry such that it will be beneficial to hordes of humanity? Things like this. And truth be told, I think we've hit both of those with this presentation, and we are really, really excited to have Dr. Susana Marcos with us to tell us about this. I won't read the entire bio, but if you are on our YouTube page, feel free to pause and scroll down to see it. Or if you are on our SiliconValleyRotary.com page, you can pause and scroll up to see it. But just know it's an impressive bio. So there you go. Dr. Marcos, what an honor it is for us to have you present to us. And we are really excited to learn more about the work you are doing. I hand the mic over to you. Thank you for being with us.
Well, thank you. Thank you very much. It's really an honor to be here and present and share our work in science and in applications in ophthalmology and actually our experience on bringing this science into technologies that are used in everyday clinical practice and even in remote areas. I am Susana Marcos. I'm at the University of Rochester. The work I'm going to present corresponds to work that I've done over the years, including work I've done in my former institution, CSIC, where you can see some pictures there. I moved from Madrid, Spain, to the University of Rochester, where I hold the directorship of the Center for Visual Science. I'm a professor of optics and a professor of ophthalmology. And what you see here is probably representative of the work I'm going to present, where there is a lot of transdisciplinary collaborations that have led us to really pursue our endeavors and read the applications I'm going to describe. I am a scientist, and I think what you will see in my presentation are examples of how, on the one hand, basic science fuels new technologies that in turn will benefit society, and also how technical innovations fuel new breakthroughs in science. So I think rather than a linear fashion going from science to benefits of mankind, there is a kind of a feedback loop between these three areas. Science starts by curiosity and imagination. It's not arbitrary that I chose this image of a child looking through a window to the stars, right? Wondering about the universe and about what it's out there. This is how I think science starts, right? It's really like being a child and being curious and being imaginative. Innovation really goes around development and transfer technologies that improve human welfare. So in a sense, we have these questions, we need to seek the answers. And in many cases, technology gives us those answers. Of course, as I mentioned, cooperation is key. Where you're going to also to see in the examples I'm going to present is a true collaboration between academia, industry, and clinic. And again, that feedback loop where not it happens linearly, but actually in a feedback loop. And also a strong collaboration between disciplines. I'm a physicist by training, doing optical engineering and work with biomedical engineers, vision scientists, biologists, material scientists, optometrists, ophthalmology. So these breakthroughs and really the possibility of bringing science to society has happened through collaboration and these trans and interdisciplinary collaborations. So our research aims at seeking answers to fundamental questions about the human visual system, right? We have the eyes, and those eyes project the images of the outside world onto the retina. So our questions are, what are the eye imaging forming capabilities? How these cornea and crystalline lens combine and form the images on the retina? How the eye keeps these images in focus, and what happens when these fails? We are interested in relating the retinal image quality with perception, with neural adaptation, working on the aging of the crystalline lens, the microstructural basis for the biomechanics of the cornea, the crystalline lens and sclera, and basic mechanisms of myopia, presbyopia, cataract, and corneal disease. How this relates to innovation and really bring in innovation from other disciplines. In our case, as far as astronomy to ophthalmology. We're actually using similar technologies than the ones that had been developed for ground-based telescopes to improve the resolution and the quality of the images of the stars. On the other hand, our innovations in ophthalmology have the potential to benefit millions. As I said, in science, we start with questions. In our case, it's questions about the cornea, the crystalline lens, the retina. The research has inspired developing of new technologies, which we have transferred to the clinic. And on the other hand, our new technologies have fueled new discoveries on the normal and pathological eye and inspired new therapeutical interventions. So let's start with the eye and how the eye that has these wonderful properties also suffers from imperfections that degrade the image projected on the retina. As I said, the eye is like a camera where the lenses project the images of the outside world on the retina, and those are degraded. So how we measure these degradations? This is where we resort to astronomy and use Harmonic wavefront sensing technologies that the ground-based telescopes use to assess the imperfections produced by atmospheric turbulence. Well, we use that technology to assess the imperfections of the eye. In those ground-based telescopes, the big telescopes have a technique called adaptive optics that is built upon mirrors that deform to correct for the aberrations caused by the atmospheric turbulence. These are images captured by the Keck telescope. You see when the adaptive optics is off, the images of these stars are blurred, and we gain really resolution and detail when we turn on the adaptive optics, this deformable mirror that corrects the aberrations of the atmospheric turbulence. Well, what we've used is that we're using these adaptive optics to correct the aberrations of the eye so that we can sharpen the images projected on the retina. We can also manipulate and create any correction through this deformable mirror. In this case, by correcting the aberrations, we will get sharp images on the retina, but we can also mimic what happens in disease when the cornea and crystalline lens get distorted, or what happens when we put a correction in the eye. This technology, adaptive optics, has also been used, and these are images from the University of Rochester, to produce unprecedented resolution of the images obtained from the retina, in this case, the photoreceptors, the cones, the cone mosaic in the retina. Well, this is how an adaptive optics visual simulator looks in the optical table in the lab. We have a wavefront sensor that measures these aberrations of the eye, and we have these adaptive optics mirrors that either correct the aberrations or induce aberrations, mimicking different corrections in the eye. Well, among those optical imperfections, the one that is most significant is myopia. In myopia, these cornea and crystalline lens project the image in front of the retina, meaning that the eye is too long and the images on the retina gets defocused. Well, myopia has been corrected for years. This is a painting by Greco in the 1600s. I think the first record of a painting with spectacles goes back to the 1300s. Well, those spectacles are still used today, but myopia is actually increasing in the population. It affects about 30% of the population in Western countries. This is increasing at a rapid rate everywhere. And in fact, 90% of children in some Asian populations are myopes. So it's kind of a new pandemic, myopia. On the other hand, myopia is a global burden for many reasons. I mean, these longer eyes tend to have more ocular conditions, but also it's a global burden, particularly in low-resource areas, because many people are not corrected. In fact, according to the World Health Organization, over 153 million people are visually impaired due to uncorrected refractive errors. And they are urging to develop affordable technologies for accessible, accurate refraction. In fact, glasses are one of the most effective healthcare technologies. You can acquire eyeglasses in certain areas in the world by less than $4, but their eye prescription is not available to everywhere. Why? Because there's a shortage of eye care specialists. In the US, for example, there's one optometrist every 6,000 people. In real India, there's one optometrist every a 250,000. That is what happens when the eye van or the vision van comes once in a while to one of those villages that do not have access care. These long lines of people trying to get a prescription. Current methods require a skilled optometrist to perform and also require time. So we can do that fast and accurate. We would be providing prescriptions to those people in need. And this is what the Quicksee does. So what we did is remember these Harman-Schach wavefront sensors from telescopes from our optical bench in collaboration with MIT and Vision Consortium. We developed these wavefront sensors in a small footprint. In fact, they're now binocular. And the good news is that there is a really good agreement between the prescription that we get using these wavefront sensing technologies and deploying it to this portable device compared to the best objective refraction that is probably 1 order of magnitude more expensive, and compared to subjective refraction that takes a long time to perform, so that we can get a really accurate prescription at the click of a button. And this is what's the Quicksee. It's a low-cost, portable, accurate auto-refraction. It's commercialized by Planoptica. It's been awarded many awards. And what is important is used in over 5 million patients right now in more than 45 countries, and using that to transform their lives with clear vision, because now they had access to prescription and a correction. So Quicksee is delivering vision care where it's most needed. And if you go to the Planoptica website, you can see many of the projects where this is going and is being used. So we talk about myopia, which is increasing and is a failure of the actual length of the eye to meet the power of the lenses. There is another very common condition in the eye, which is presbyopia. Presbyopia is the crystalline lens that what you see here is a reshaping to accommodate eyes objects that are presented near and far. And this is again coming from the lab, from a new technology that we have developed to measure these changes of the crystalline lens in vivo. This is what happens in the young crystalline lens. With aging, the crystalline lens can no longer reshape. It becomes stiff, and we cannot accommodate dynamically. And this is what happens, right? Even either people have to put their targets very close, the arms are not long enough, or they have to remove their spectacles if they're myopes. Presbyopia affects 100% of the population over the age of 45, and there is 1.8 billion people worldwide that are presbyopes. There's multiple ways to compensate for presbyopia. None of them restore the accommodation capability of the eye. But there is an increasingly popular correction of presbyopia called simultaneous vision. These are multifocal, either contact lenses or intraocular lenses, even corneal surgery, where now a multifocal lens is prescribed that extends the depth of vision by producing simultaneously images that focus as far and near at the expense of decreasing quality in both distances. There is also the possibility for monovision where one eye is corrected for far, the other eye is corrected for near. It is very hard to understand and imagine how you're going to see with these corrections, particularly when you're going to be implanted with an intraocular lens, with a multifocal lens, or you're going through surgery, or even if you have to try different contact lenses in the eye to try which one best works. Well, with SimVis, we have gone from the adaptive optical systems, the big optical tables, inspired again by the adaptive optics in astronomy, to reduce the footprint to work with a portable device. It's a binocular device. It works by the principle of temporal multiplexing, where an optotunable lens is driven very fast to produce static image on the retina that reflects the multifocal properties of the lenses. We have shown that there is a good agreement between the vision that is simulated preoperatively with the lenses simulated in the SimVis, and there's many, many different corrections available and lenses in the market, and the lenses that are the vision post-operatively with the implanted lenses. So with the SimVis, we're giving patients the experience of post-op vision. There is this uncertainty by the clinicians and by the doctors and how I'm going to see with treatment, and the doctor saying, is this going to be a happy patient? Is it a suitable candidate? Well, now with this portable visual simulator, they can actually experience how the world is going to look through real corrections. This can be intraocular lenses, contact lenses, presbyopic laser, or fine-tuning between corrections in a binocular combination. The device, the SimVis Gecko is the commercial name, is developed by the company Two Eyes Vision, and is now being used in 11 countries to custom the needs of presbyopic patients and manage their patient expectations. So I think what I try to convey is that we can actually start by asking questions in science and getting inspired by apparently so far disciplines as astronomy, and looking at the stars in higher resolution to bring those technologies to ophthalmology. We first started with optical benches and testing these technologies in the lab and doing real cool science with it. But we can also transfer this technology, and I showed two examples, the Quicksee for getting eye prescriptions and the SimVis Gecko for giving the patients the experience of a multifocal correction. We're bringing those technologies to those that will benefit from it. And I think this is just an example of what science and interdisciplinary collaborations and meeting science and technology and clinic what can actually do to help patients and to improve eye care and quality of life. And I thank you very much for your attention. You're welcome to reach me at the email address I'm showing in this last slide. Thank you so much for your attention.
Excellent, Dr. Marcos. Thank you very much. I think our next move is to introduce the group that we've got. If you'd like to go ahead and stop sharing there for a minute, we'll say hello to everybody. From here in the Bay Area, from our club, and I'll ask that that each person wave to the camera almost to get there. And Dr. Marcos, I'll have you stop sharing here for just a minute so that we can kind of see the group. Our paella master in Walnut Creek, that's Shag Shagrin. Thank you for being here. Sandy, also here in the Bay Area, retired nurse and serial participant in cleft palate surgery missions. Very, very cool. We have in Houston, Texas, Roy Olson. We have in Vancouver, our president of the club, Nick Lagarde. We have one of our founding members and part of the District 7040 Passport Club, Chris Cochran, currently in Florida. My name is Rushton. I am in San Jose, California. And Dr. Marcus, let's jump into these questions. So when we talk about the potential for a low cost device that can identify prescriptions and give people the opportunity to experience what a corrected vision for them will seem like. This is in the field now. Where are you doing this in different parts of the world if it's advanced that far?
Yeah, it's actually in 45 different countries at the moment. And that comprises developing countries. So first units started to be sold in India, but it's basically all over. It's also being used in screening. So there is actually different devices, and one is actually in many optometrist offices. So the idea is that this is a technology that can be really used in remote areas. It's portable, it's easy to use, but it's also, part of the day-to-day instrumentation in optometry, where you really want to get an accurate prescription for prescribing glasses. Mm-hmm.
Nice. Sandy asks if there is anything about the device that limits which populations can use it. So can it be used with children?
Absolutely. There's actually multiple publications showing it's used to prescribe glasses for children. And as I mentioned, myopia is increasing. I said 30% of the population in Western countries, but it's actually increasing by the day. The pandemic has been shown to be like a time where myopia increased. Is related to indoors and near work. So yes, children need to be screened and need to be prescribed with glasses, and also there's new techniques for myopia control. They need to be evaluated. So absolutely, it's one of the main targets.
Good. And one of the stats in your slides had to do with the high prevalence of myopia in children in some Asian countries. And this, of course, predates the pandemic. So are there particular things that researchers have been able to bring forward as likely causes of the higher incidence of myopia in those countries? And which countries are we talking about, by the way?
Yeah, so we're talking about Singapore, Hong Kong. So it's mostly urban areas in Asia and Southeast Asia, but it's also highly prevalent in other populations. There is early work where ultra Orthodox Jews have over 80% of myopia prevalence. It appears to be linked to near work. And to performing, work indoors, and lack of exposure to sunlight. But it's actually an intriguing question. So it's we talked about myopia and curiosity driven and asking questions. This is still a big question, and we're actually working with the National Academy of Sciences on a program called Focus on Myopia, because there is many questions still to be asked. And again, new technologies will help us to understand the mechanisms, and will help us to find solutions.
So Chris asked a question about the business end of the work being done through Quicksee and Two Eyes Vision. What is the cost of the device, and how are you finding that funding to work? In part because I'm imagining that if it is, and it seems to be significantly cheaper than traditional devices. How do the market forces end up affecting how different organizations might make choices there? I can imagine that there would be some pushback by entrenched pieces of that market.
Yeah, it's the Quicksee is significantly lower. It's about an order of magnitude of kind of the state of the art autorefractometry. So it's significantly lower, but as I said, there is a big push, including some of the big manufacturers, of spectacles to actually bring the process of arriving to a prescription to be more easier and faster. So this is actually in favor of like increasing prescriptions, and it's not meant to be a competition to optometrists, but actually a tool for those optometrists. The market for SimVis is very different in respect of that being a completely new technology, right? There is auto-refractometers, there is a selective refraction that compete in the space of the Quicksee, but SimVis is the very first binocular visual simulator that can convey the patients the experience of these multifocal lenses. It's not a virtual reality headset. It's actually a see-through real world like representation of how these lenses work. So they're it's a pioneering. There is of course other barriers when that happens, because you really need to capture the first users. But what we've seen is that there is such a need for both patients to understand, because they're facing. It's like when you go and buy a car, right? You want to drive it first. You would like to see how you're going to see with those intraocular lenses that you're going to have permanently in your eyes, right? And on the other hand, the surgeons, they are for the first time being able to now tell with words how they're going to see, but they actually can educate the patients and actually show the patients the different possibilities. So we find this a win-win in the sense of patients win the experience, clinicians are more confident in the final treatment they're going to prescribe. And also the manufacturers of those intraocular lenses have for the first time a platform where they can actually showcase the different lenses they have in the portfolios. So I think this is something that has been highly regarded by the market and by investors. The fact that this is an innovation that helps basically all the stakeholders involved.
I would imagine that getting these kinds of technologies into the hands of more and more people anywhere in the world means that you are also gathering more data about the kinds of conditions that you are seeking to alleviate with them. Has that brought any surprises to your research team in terms of how they're moving the research forward?
Mm-hmm. Yeah, that's an excellent question, and I see two sides of it. So the first one is, we can actually explore what happens with one patient that can choose now across different lenses, and we can actually see what are the patient's preferences and how they relate to specific properties, whether it's age or their optical conditions, or their prior adaptation, whatever. So this is actually science, right? But we can also help, because the system, and I'm talking here about the SimVis, it works. It's a platform, and then there's a series of lenses that are programmable, and it's run through an iPad that connects with the device and also collects the information. So there is a big back end where now we can gather data, and we can actually do a lot of data analysis and data science regarding preferences across lenses, and how patients respond to a given correction. And those are corrections in many cases that they're going to have one. So there's never been the ability to test and compare across different options.
Well, along those lines, one of the most powerful visuals in your presentation is the image from India and the long lines of people waiting to go to the van, right? Rotary is famous for its leading role in the effort to eliminate polio. And in a sense, that's really a combination of the development of a technology related to the vaccine and how to transport it, and then the partnership with an organization, Rotary, willing to get people on the ground all over the world in order to deliver those vaccines to children. When thinking about something like, one professional optometrist, ophthalmologist in India for every 250,000 people, is it that there are certain organizations that have stepped up to assist in the work to allow this technology to benefit more and more people across that country or a similar country?
Absolutely, absolutely. Planoptica has partnered with different organizations and NGOs. So there's been things ranging from campaigns to actually have the Quicksee as the technology of choice for sight savers and many of the different campaigns from ophthalmology and optometry is going to developing countries. Also, you can transport that into those regions of the world, but also home, right? So Planoptica has partnered with Pittsburgh and is bringing this technology to poor resourced areas in the city. And there's many organizations, and I work as part of the Flaum Institute, Department of Ophthalmology at the University of Rochester. They tend to have these vans that provide vision screening to children. So this is definitely a really suitable technique to bring in those vans.
Well, fantastic. We'll wind things down, although for all of our folks who are on the call, one of the great things about being part of these recordings is that we get to keep talking with these amazing people after we do them. So that's wonderful for us, and for you, join the next one. All good. So I'll hand it back to Dr. Marcos in a moment for a final word. But for all of you who might be watching this recording, we hope that you will find in our library of videos, our meetings archive on SiliconValleyRotary.com and in our YouTube channel, all sorts of stories of people who are doing really amazing things. There are all kinds of reasons to be hopeful about what's possible in the world. And if you just watch the doom-focused news, you might not understand that. So by all means, feel free to take a look. You can find our site at rotary.cool. If you are watching this from the embed on our meeting page, then scroll down a bit where we have our Discuss forum and leave a comment about what you learned as a part of Dr. Marcos's presentation or any other element of the meeting. As we always do, we hand it back to the speaker for the final word. Dr. Marcos, what would you like people to have in mind as they finish the video?
Well, thank you very much for the opportunity. It's great to be part of this community, and it's also, I think, the take-home message is that how science can actually bring things that are disconnected in principle, but then we can bring them together, work cooperatively, and have technologies that come from astronomy into optics and ophthalmology to actually improve vision.
Wonderful. Thank you, Dr. Marcos. Thank you, everybody, for your questions in our gallery here. And for all of you watching these videos, we hope that you will come back and watch more of what we do, and we look forward to seeing you next week.